I hope you can see my screen. That's true.
Yes. We can start. So we are presenting BM, a 2-year, 8-month-old male child who was admitted on 1st of March 2026 at the Kenyatta National Hospital Pediatric Ward 3B. He's a resident of Kayole, Nairobi, and the history was given by the mother, who's a reliable informant. So the child presented with delayed milestones since infancy and convulsions for the last 4 weeks. According to the mother, the child was well until 4 weeks prior to admission, when the mother noticed the first episode of convulsion. The convulsion had a sudden onset while the child was awake. It began with the child becoming suddenly unresponsive, followed by upward rolling of the eyes, then rhythmic jerky movements involving both upper and lower limbs. The jerky movements were bilateral, symmetrical, and associated with generalized body stiffening. So, according to the mother, the episode lasted approximately 3 minutes and resolved spontaneously. So, during the event, the mom reports that there was associated loss of awareness, frothing at the mouth, perioral cyanosis, and an episode of urinary incontinence. However, there was no history of tongue biting or fecal incontinence. Following the event, the mom reports the child became drowsy and slept for about 30 minutes, after which he returned to his usual baseline. So the progression was, since the first event, the mom reports the seizures the seizures have been recurring 2 to 3 times per week over the last 4 weeks, all with a similar pattern. However, there is no history of associated fever, no history of recent respiratory symptoms, no diarrhea, no history of vomiting, head trauma, toxin ingestion, or missed feeds. There is also no history of focal weaknesses after the episodes, altered behavior between episodes, or regression of previously attained milestones. So the caregiver also reports that even before the onset of convulsions, she had long-standing concerns about the child's development. She stated that since infancy, the child had delayed attainment of motor milestones. So at 4 months, he had poor head control and was unable to sustain neck posture. By 8 months, he was unable to sit without support, and at 1 year, he had not started crawling or walking yet. So currently, at 2 years, 8 months, he is unable to stand or walk independently. When supported upright, the mother notices that the lower limbs become stiff and cross over each other. Yeah. So there is associated delayed speech for age, difficulty in feeding with occasional choking, and drooling of saliva. However, there is no history of loss of already attained milestones, sensory deficits noticed by the caregiver, or chronic cough or recurrent aspiration pneumonia. So the child was delivered at term, that is 39 weeks gestation, in a private facility via SPD. The birth weight was 3.2 kgs. According to the mother, the baby did not transition well after birth and required resuscitation immediately. He was then admitted to the NBU for 5 days. There is also a positive history of poor sucking during the first few days of life. For the past medical history, the child has a history of admission to the NBU unit for 5 days after birth due to breathing difficulties. He has had multiple visits to clinics since the child being 1.5 years old due to the delayed milestones. No history of surgery, no known drug allergies, and no prior blood transfusions. So for the NC history, the mom is a para 1+0. She had attended a total of 4 NC visits at Kayole Sub-County Health Center. The pregnancy was complicated by pregnancy-induced hypertension in her 32nd week of gestation, but was controlled using antihypertensive. So there's no history of increased readings of RBS, fevers or rashes, trauma, alcohol or cigarettes use or herbal medication. And she was routinely taking her hematinics during her pregnancy. So for the child's growth and development history, for gross motor, the child had poor head control, which was attained at 6 months, sat with support at around 1 year. The child cannot crawl, stand, or walk. So for fine motor, he reaches for objects with the right hand only. And then for language, he babbled late and says bisyllabic words like mama and baba, which the mother noticed after the child had already turned a year. For the social, he recognizes the mother, smiles socially, but has poor play interaction with other kids. So yeah, for the growth part, on inquiry, the mom noted the child has not been gaining weight appropriately, and when she used to go to the postnatal clinic, the child is usually below the growth, below the chart, below the curve of the growth chart. So in conclusion, the child had global developmental delay. So for nutritional history, the child was exclusively breastfed for 4 months, then mixed fed with formula milk and oats. Currently on family diet, but feeding is difficult because of poor swallowing, prolonged feeding time, frequent choking, and occasional drooling. The mom notes that the appetite of the child is just normal and is fair. So for the immunization history, the child is up to date as per KP schedule. And for the family history, this is a first. So this is a firstborn. They have no family history of developmental delay, no history of epilepsy in the family. The child lives with both parents in Kayole. The father is a construction worker. The mom is the primary caregiver. She also quit work to fully commit to taking care of the child since the child is fully dependent on the mother for feeding, mobility, toileting, and dressing. They have an active SHA. So on physical exam, on general exam, the child was lying supine, was awake and alert, was not in any respiratory distress, or no obvious dysmorphic features were seen, had a mild drooling of saliva, mild drooling of saliva, mild wasting of lower limbs, no jaundice, no cyanosis, no edema, no significant lymphadenopathy. So the vital signs were normal, with the temperatures being normal. The pulse were 108 beats per normal, regular of normal volume. The rest rates were normal, and so were the SpO2. For the nutritional assessment, the child's current weight was at 10.2 kg, which is a bit low. Height was at 89 centimeters. The mark of the child was at 12.4. The weight, height, Z score was at -2 standard deviation. So we noted that the child was moderately malnutritioned. So next was the CNS examination. The child was lying supine and the posture was normal and symmetrical. Child was conscious and responsive to the mother, had poor eye contact but follows visual stimuli, nonverbal, appears to recognize the mother, had a head circumference of 48 centimeters with no obvious syndromic features. For the head and neck, the child had no neck stiffness, had negative Canning sign and Brzezinski's sign. For the cranial nerve, the pupils were bilaterally reactive to light. For the third, fourth, and the sixth nerve, we noted by observing the child's movement of the eyes, so his extraocular movements were intact. For the facial nerve, the child had no facial asymmetry. Hearing was grossly intact to voice, or when like there's something that falls down, the child will like move the head to the voices stimuli. And then for cranial nerve 9, 10, and 12, the exam was mainly based on observation. So there was drooling, and during feeding, we noted that the child would cough. Yeah. So for the motor examination on inspection, we noted that there was reduced bulk in both upper limb and lower limbs, no fasciculations, no tremors, or no abnormal movements were noted. For tone, we noted that there was increased tone in both limbs. However, it was more increased. The tone was more increased in lower limbs compared to upper limbs. And for power, for the upper limb, for the distal muscles, we noted that the MRC grade was at 3. And for the proximal muscles, we noted that the MRC grade was at 2. And for the lower limbs, both the distal and the proximal muscle groups, we noted that the MRC grade was that of 2. And then for the reflexes, so the knee-jerk reflexes were increased bilaterally. So were the ankle jerk reflexes. There was myoclonus, and Babinski was also upgoing. We also noted primitive reflexes that had persisted were the asymmetric tonic neck reflexes and plantar reflexes that were still present. So for the posture and gait, the child is unable to walk on vertical suspension. He assumes a scissoring posture, and on horizontal suspension, we noted a poor truncal control. So for we classified this according to the gross motor function classification. The score, we scored it around 4 to 5. Angela would go deep on that later on when discussing this. So other systems were unremarkable. So in summary, this is BM, a 2-year, 8-month-old male child. Generalized convulsions will delay. He has a significant requiring resuscitation and involving all the 4 limbs to reflexes. This child had a convulsive disorder with spastic quadriplegic cerebral ischemic encephalopathy. So for the investigations, so a random blood sugar was taken and it was normal. The full blood count was normal. For the UECs, Angela next. For the UECs as well, the UECs were normal. Calcium and magnesium levels were normal as well. And then for the EEG, which was it showed a background slowing with right frontoparietal sharp waves and secondary generalized discharges. Brain MRI was done, and it showed periventricular leukomalacia and mild cortical atrophy. So for management, the management included seizure control. So the child was on anticonvulsants. Spasticity management was done after the child was given oral baclofen. The child had a multidisciplinary review by a nutritionist, a physiotherapist, and an occupational therapist. Yeah, and the child was monitored for aspirational pneumonia and convulsions. So that's it on the case presentation part. And now let Angela take us through the topic.
Hi, good evening. My name is Angela Modhoni, and I'll be presenting on cerebral palsy together with Nasra, my colleague who just finished. Okay. So what is cerebral palsy? It is a group of permanent disorders of development of movement, posture, and balance due to a non-progressive disturbance that occurred in the developing fetal or infant brain. So something to note is it impairs your development of movement. So you'll see problems with movement, with posture and balance. And it's usually as a result of a static injury, an injury that happens once, and it's usually to the developing fetal, infant, or brain. So the brain has to be developing. Some of the statistics around it is around 17 million people are living with cerebral palsy right now worldwide. The prevalence is 1.5 to 3 per 1,000 live births, which is quite high. And it is one of the most common cause of dystonia, just abnormal repetitive movements in children. The populations that are a bit at a higher risk, and that's preterm infants and low birth weight infants. So that's less than 2.5 kilogram. But also something to note is about 50% of the children with cerebral palsy actually have no identifiable risk factors. Some other key statistics are about 10% of the cases are as a result of postneonatal onset, and 10% are usually associated with some form of birth asphyxia. So low Apgar scoring by 5 to 10 minutes, about 10% is as a result of that. So some of the risk factors we look at, first of all, preconception. So if the mom has a history of miscarriages, has a history of stillbirth, this could point towards some autoimmune condition that would cause uteroplacental insufficiency and cause hypoxic damage to the fetus when they're still in utero. So it's good to just find out if they have a history of this. Some of the risk factors prenatally are congenital brain malformations. In case the mom had any intrauterine infection, since it can spread vertically from the mom to the baby and cause problems with development, and also hypoxic injury, preeclampsia because of the uteroplacental insufficiency, multiple gestation also because of the same, and IUGR and prematurity, which are one of the major risk factors, especially for prematurity. The children tend to have periventricular hemorrhages that can lead to periventricular leukomalacia, and that can predispose them to getting cerebral palsy, and also genetic abnormalities. Some other risk factors perinatally is birth asphyxia. So poor Apgar scoring by 5 minutes, which would lead to hypoxic ischemic encephalopathy, and also seizures, jaundice, and infection. Postnatally, we have neonatal jaundice, so canicterus, when the unconjugated bilirubin crosses the blood-brain barrier, and it tends to affect the basal ganglia. It has a predilection to affecting the basal ganglia specifically, and it would cause cerebral palsy, dyskinetic cerebral palsy, which we'll talk about it a bit later. Then we have CNS infections, any history of a trauma or stroke. So the pathophysiology is usually as a result of injury affecting either the motor cortex, the basal ganglia, and the cerebellum. And depending on what structure it affects, it will present in a particular way. And it will lead to abnormalities in either the muscle tone, reflexes, posture, and muscle coordination. So classification of cerebral palsy, it's majorly a disorder, a motor disorder, primarily a motor disorder, and we can have spastic, dyskinetic, and ataxic. So for the spastic cerebral palsy, it's one of the most common, and it affects the motor cortex. So it will present like an upper motor neuron lesion with increased tone, hyperreflexia, and stiff movements. For the dyskinetic, it's usually majorly, especially if a child had kernicterus, they tend to have dyskinetic cerebral palsy, and it's usually as a result of injury to the basal ganglia, and they will tend to present with abnormal movements like chorea and athetosis. So these are like slow writhing movements, and dystonia. Also ataxia if there's injury to the cerebellum, and they will present with poor balance, tremors, and a wide-based gait. And we can also have a mixed type, which has some spastic features as well as some dyskinetic features. So we can also classify them by distribution. So we have the hemiplegia, where half of the body is affected, then diplegia, where the lower limbs are affected more than the upper limbs, then quadriplegia, where all the limbs are affected. Some of the clinical features that you might see are the most important one is the delayed milestones at expected age. So the gross, especially the gross motor milestones, they tend to be delayed, and majority of the parents would come presenting with this. Then they'd also present with abnormal muscle and also stiff arms and legs, scissoring, especially of the legs, an arched back, a retracted neck, or just a floppy posture. They'd also have abnormalities of gait, and also persistent toe walking. This is usually as a result of the spasticity of the gastrocnemius muscle. So they'll have persistent toe walking. Then also persistence of their reflexes. So you tend to see the primitive motor reflexes, and also they can have early hand preference. Essentially, they're supposed to develop by 18 months, but if they develop maybe by 1 year, that's a bit early, and it could point towards a hemiplegia. So they'll probably use the side that is not affected more. Other associated features are seizures, intellectual disability, speech delay. Also, they can have hearing and visual impairment, especially the hearing impairment. It's usually a neurological sequelae of kernicterus. Then we have also feeding difficulties because they're not able to coordinate their oromotor muscles. Muscles. So they'll tend to present with choking during feeds and also a lot of drooling. And they can also have behavioral and problems as well as emotional dysregulations. These are okay, sorry. Some of the milestones that they should have achieved. So I can just give an example. Let's say they're able to hold their head by around 1 to 3 months. So if it's delayed, it raises your index of suspicion. Let's say the one for pulling to stand, it should be around 9 to 13 months. If they're not able to by 13 months, it should also raise your index of suspicion. There's the functional assessment, the one that my colleague Nasra was talking about. So it is a 5-level scheme to evaluate essentially the gross motor function in children with cerebral palsy, and it pays specific attention to whether or not these children are able to have head control, if they're able to sit independently, and also if there's presence of any independent mobility. And it can be used to determine the prognosis of cerebral palsy as it remains stable after 2 years. So whatever score that child gets by the age of 2, they'll probably just remain there. So this is what it talks about. It's graded on different levels. The higher the level, the worse the immobility, the more immobile the child is. So for the level 1, we have that the child, as you can see here on my bottom left, the child is able to walk without any limitation, so they can even climb stairs without any limitation. Then for level 2, they walk with a bit of limitation. So especially when they're going up the stairs, they'd use the rails for support. Then for level 3, they walk using a handheld mobility device. So as you can see, this child here is walking using crutches, especially for short distances, maybe when they're in the house. But let's say when they're going to school, they'd need to use a wheelchair. They can use a manual wheelchair since they're able to push it, or an electric one. Then for the level 4, they have self-mobility with limitations. So they have some form of mobility, but they really, really get tired. So it causes limitations and they may use powered mobility. So as you can see here, they're walking with a walker. So this is only like inside the house. But if they need to go to school or just outside, they'd have to use a wheelchair. Like this child is using an electric wheelchair. Then for level 5, they're transported in a manual wheelchair. They are completely immobile. And as you can see here, they also don't have the head support as well as the truncal support. So they tend to be strapped here, the head and also the chest. And then they use a manual wheelchair where someone will just push them. Then for diagnosis, it is difficult to make a certain diagnosis of cerebral palsy within the first 1 to 2 years of life. But if a child has high risk factors, screening leads, if a child has a high risk factor, let's say a risk factor of like birth asphyxia, it will lead to screening. We'd need to screen early for early diagnosis management. If you have early diagnosis and management, it would have better long-term outcomes. For a child with no risk factors, they often present when parents note delayed milestones. And then some of the screening tools that we can use for children even younger than 2 years are the GMA, the General Movement Assessment, and the HIND, which is the Hammersmith Infant and Neurologic Examination. These two are screening tools, and they actually have a very high sensitivity for diagnosing cerebral palsy. For the GMA, it has a 98% sensitivity and the HIND has a 90%. So for the general movement assessment, essentially it's just an observational assessment where you observe the spontaneous motor activity of infants. Infants, newborns, they have motor activities that are very specific to them. So if you see maybe sometimes they fidget, so if you see, let's say, absent fidgety movements, it can raise your index of suspicion. Especially this one, it's very sensitive for that. And also cramped synchronous general movements. This just means like contractions, weird contractions. Then for the HINE, which is the Hammersmith Infant Neurologic Exam, it's a structured and standardized neurological exam for infants. And the target age range is usually 2 to 24 months. The GMA, it's less than 5 months. And it uses the neurological exam to be able to score these children. And the higher the score, the less the chances of them getting, but the lower the score, I think less than 57, the higher the chances of them developing cerebral palsy. They help screen for cerebral palsy for children younger than 2 years. Then some of the other investigations you can do are brain imaging. The MRI is it's better, it's preferred. It has a very high sensitivity, and using the brain MRI, you can be able to see the brain parenchyma to see lesions such as, like you can see the cortical dysplasias, you can see, let's say, like the smooth brain, the schizencephaly. In case there's any periventricular locomalacia, you'd be able to see all that using an MRI. You can also assess the hearing and vision. You can also do an EEG for patients with seizures so that you know seizure activity, and then metabolic, and you can do metabolic tests to also rule out other metabolic conditions that would also present in a similar way, like let's say the lysosomal storage disorders. Then monitoring using the full blood counts, where we look at the white blood cell counts, for infections, also the bone biochemistry, because these children tend to not be taken outside in the sun a lot, and also they have malnutrition problems because of feeding problems. So this would also be very important to do, and also your UVCs. So for the diagnosis of cerebral palsy, it's established based on a combination of critical factors such as the clinical risk factors, the neuroimaging findings that you'd see on your MRI, and neurological assessment. So management goals. So for cerebral palsy, the management is multidisciplinary, involves so many people, the nutritionist, pediatrician, orthopedic surgeon, psychologist. It's just a whole list of people. And the main aims is to improve functional improvement, so to improve the motor functioning skills, also improve mobility and the physical health, improve also communication and prevention of complications, because it's associated with quite a number of complications. For For management, we'll start with rehabilitation and therapy. So the first one is physiotherapy. So they need to go for physiotherapy for stretching programs to prevent formation of joint contractures and just increase the mobility of the joints. Also for the speech and language therapy, for the functioning of the oramotor muscles, it can also help with swallowing. Also occupational therapy. This is just to help them be able to do the normal day-to-day activities according to what they're able to do, and also help them to know how to use the different adaptive equipments like the walkers, wheelchairs, and canes. Then another important thing in management is parental and caregiver support, because essentially there's no cure. We're just managing the symptoms, preventing comorbidities, and just improving the life of that child. So counseling for psychological support for the parents, because some of them might be fully dependent on the parents, and it might take an emotional toll. So just counseling them. Also parental education, telling them how to do those stretches at home, or even when a child has a seizure, what to do, just those important things. And also support groups for different parents with children with cerebral palsy, so that they know that they're not alone. There's also nutritional support. It's essential to prevent malnutrition, especially when there are swallowing difficulties present, and they might have some GIT functions. So they might have delayed gastric emptying, and the delayed gastric emptying would lead to reflux, and the reflux would also cause vomiting. And also they tend to have a lot of constipation problems. They also have feeding problems, as we have said, and they tend to choke during feeds, and this can lead to aspiration and cause aspiration pneumonia. And all this can also lead to malnutrition. So it would be very important to monitor their weight, their height, so that you're able to detect the nutritional complications. Some of the pharmacological therapy is, some of the complications you have is like spasticity. So for spasticity, you can use benzodiazepines like diazepam to treat. You can use baclofen, tinazidine, and botulinum toxin. Also for the dystonia, you can use them gabapentin. For the seizures, you can use different anticonvulsants, levetiracetam, phenobab. For the sialorrhea, which is excessive drooling, you can use antimuscarinics like glycopyrrolate, atropine drops. For the pain, which is a common complication, you can use analgesics and anti-inflammatories. And also for the constipation, you can use stool softeners and promotility drugs. For the mental health, you can use antidepressants to prevent depression and anxiety, in addition to counseling. Surgical management, they might need the orthopedic surgeries to correct different musculoskeletal complications like contractures. They might need tendon lengthening. They tend to get a lot of hip dislocation due to that spasticity. So it can cause hip subluxation that would lead to eventual hip dislocation. So even when the child comes, it's just good to check the hips for any subluxation or dislocation. Also, managing fractures. Another treatment that can be done is the selective dorsal rhizotomy, which is a neurosurgical intervention where selected nerve rootlets are cut to reduce spasticity and improve mobility. Because essentially, cerebral palsy spastic is as a result of injury to the motor cortex, which will present with an upper motor neuron lesion. So when there's that, there'll be a lot of spasticity. So for that, they can do the cutting of those nerve rootlets to reduce the spasticity, and it's essentially effective for spastic diplegic cerebral palsy. Some of the complications they tend to have are in neurological. They tend to have intellectual disability. They can present with seizures, epilepsy. They can also have sleep disturbances. They can also present with a lot of pain as a result of that stiffening of the muscles, spasticity of the muscles, osteopenia. They can also have osteopenia because of reduced weight bearing, hip dislocation because of the spasticity, scoliosis as well, also speech, hearing impairment, and blindness. And some of the other systemic complications that they would present with are for pulmonary disease because of the aspiration pneumonia and also urinary incontinence. Prevention, of course, focusing on preventing preterm delivery, which entails a lot of things, proper ANC care, also detecting placental issues, like PV bleeding, antepartum hemorrhage, or preeclampsia, anything that will lead to uteroplacental insufficiency, like identifying and managing early, also diagnosis and management of maternal infections during pregnancy, because this can predispose them to getting a preterm labor, and also therapeutic hypothermia. This is used especially for children who get birth asphyxia. It's usually within the first 6 hours, they usually put under a cooler for about, I think, 33 to 35 degrees Celsius. And this is usually to reduce the secondary injury to the brain. Yes, in attempt to preventing them from developing hypoxic ischemic encephalopathy that would lead to cerebral palsy. Thank you.
Thank you so much, Angela. Now I'd like to invite Dr. Anjum to give us her insights, and then after I'll give room for questions and inputs, if any. Welcome, Doc.
Okay, thank you so much. It was a great presentation, and you've presented very nicely. So I just wanted to add some few points here. So first, the most important thing in cerebral palsy is the birth history. So you must inquire how long first the birth took. Did it, because it should not take more than like 12 to 18 hours, but did it take like did the mother, was she in labor for like 2 days or 3 days, in active labor, I mean, and because that will compromise the brain of the child. And then when the child was born, did the child cry immediately? So that is the Apgar score, the first one. So did the child cry immediately? Like immediately, I mean within like some few seconds, did the child cry? And how was the sucking? Did the child, because what happens is the mothers, they put we encourage the mothers to put the babies on the breast immediately. So, and the sucking reflex comes immediately. So how was the sucking reflex? And then was the child put on oxygen? So that is very important, because what happens is sometimes we see very many cases like that. The mother will tell you that the child was born okay, cried immediately, but after 2 3 days the child started convulsing and started so you think that this now is cerebral palsy, but it could not be cerebral palsy. It could be actually inborn error of metabolism. So history is very important, because there is a very close relationship between HIE, hypoxic ischemic encephalopathy, and inborn error of metabolism. So inborn error of metabolism could be anything. Maybe the child has phenylketonuria, or some urea cycle, because even those ones develop in the first few days of birth, in the neonatal period. So you have to be very careful in what you are dealing, because you might just label the child cerebral palsy, and the child could actually be having something else which you can actually prevent, because we know cerebral palsy you cannot prevent, and it is non-progressive. But inborn error of metabolism is preventable, but if you have not made the diagnosis early enough, it is progressive. So these are the two very main, very important differences. So that is what I wanted to tell you. So please don't label each and every child who comes with convulsions and spasticity as cerebral palsy. It also could be and delayed milestone, especially delayed milestone. It actually could be inborn error of metabolism. So birth history is extremely important. And so in our settings, we see spastic, a lot of spastic because of the HIE. This kinetic is very rare. I've not seen, because right now we try to prevent canicterus as soon as we see the bilirubin levels rising up, especially in RH incompatibility. We do exchange transfusion, and we can see that even that is preventable. So if you see a patient whose bilirubin is rising, so please don't waste time and struggle with phototherapy. You can just do exchange transfusion, because that will actually reverse. If the child has started developing canicterus, it will actually reverse it. Or even if it does, it will be very mild. Yeah. So I think those were my important points. Yeah. Thank you. If you have any questions, you can ask. Any questions? Maybe you can even write in the chat. So looks like there are no questions.
If there are no more questions, then we can close the meeting. Oh, there's one question. In the chat box.
Oh, okay. Sorry, I was muted. So intelligence is because there is gradual developmental delay, and we know that speech is a form of development. So because of these developmental delay, there is intelligence delay, because the motor is the basal ganglia, or in fact in cerebellum it might not be affected that much, because we know that it is not there is as one of your colleagues mentioned, there is a spectrum. So those who are mildly affected to those who are severely affected. So those who are mildly affected, maybe their intelligence may be if not very no if it could be towards somehow normal, not normal, but around there, to the intelligence which is vastly affected. So it is a spectrum. So depends on how the brain is affected. So if it is affected severely, then there will be severe defect. If it is affected mildly, then there is just very mild defect. Thank you. I hope I've answered your question.
Okay, having no more questions, we will have come to the end of our discussion. A heartfelt thank you to you, Dr. Anjum, for expertly moderating tonight's session. To our presenters, Nasra and Angela, thank you for the insightful and informative presentation. Your contributions have helped deepen our understanding of cerebral palsy, a condition that every clinician must be well prepared to manage. To everyone who joined us this evening, thank you for your time, attention, and engagement. On behalf of the Msaun KNH Academics Department, we hope this session has been both enriching and impactful. Assalamu alaikum wa rahmatullahi wa barakatuh.
Okay. Thank you, guys, and good evening.